Thank you, Tatiana. This is a great pleasure to be here in Cairo again, this wonderful city with this long and beautiful history. I am grateful for the invitation to Professor Inashal Tut and the organizing committee, and I was assigned to deal with this subject, which will try to combine two notions which actually represents two kinds of syndromes. Of course, everybody knows the metabolic syndrome and its definition, which is rather a phenotype than a common physiopathologic mechanism, whereas on the other hand, we do not have just a clear idea of what is the phenotype of what we would call stress syndrome, although we have a very clear notion of the physiopathologic reactions following the stress. So we'll try to combine both of them. This is the outline of my talk, and I will start with a definition of stress. The term stress was borrowed from physics and was said to mean the mutual actions of forces, that is, damage versus defense or resistance, which take place across any section of the body. Of course, everybody understands that this refers to a functional situation which might become deleterious. So when Hans Selye described back in the 30s the general adaptation syndrome, which is the reaction to a stressor, he starts by describing the alarm stage, which is followed by the resistance stage. It's exactly the moment when physiopathologic mechanisms react in the body. But eventually, an exhaustion stage could follow, which could lead to unrepairable damage. I found very interesting a couple of years ago in the Time magazine this description of stress, which is very clear to me. So here we have, for example, an external threat as perceived through our vision, which is defined by our body as a stressor, which demands a stress response, which starts in the brain. The stress response results to a flood of hormones which are unleashed in the circulation, and eventually this can cause significant damage. And it is very interesting to know that already in the 50s, Hans Selye, this wonderful personality, which was not recognized in his time as such a great scientist, he has so nicely described in the 50s in a single authored paper in BMJ all the systems, the hormonal systems which respond during stress reaction, including the adrenals, the pituitary, and so forth. So who do we call stressors in our daily life? Stressors can come from outside, they can come from inside. You can see here that we have all kinds of stressors, which include everyday life's nuisance, life changes, natural and other disasters, starvation, overnutrition, excessive exercise, chronic diseases, socioeconomic situation, loss of job, loss of life's control, responsibility for other persons, substance abuse, inflammation, including septic and aseptic, and of course, psychopathologic situations, including anxiety, and I have put in yellow depression as described now in typical and atypical, because I would like to use it as an example during my talk. Personality disorder as well. Just a mere point of attention, there are differences between the reaction of our body to a stressor which acts acutely and to a stressor which acts chronically. Usually, acute reaction to a stressor protects us and protects our body, organism, and life. The response to chronic stressing activity of a stressor can be really damageful. And this is the case of the involvement of stress as a metabolic syndrome. So the general reaction, as all we know, in this old cartoon, but always valid, involves two axes, involves the CRH, hypothalamic, pituitary, adrenal axis, with the secretion of CRH and vasopressin in the hypothalamus, ACTH in the cortex of the adrenal, and glucocorticoids. And on the other hand, at the locus ceruleus, here is the location of the locus ceruleus, is the epicenter of the sympathetic system from which long nerves secrete finally catecholamines. I'm not going to go through all these details of how the response to stressor is developed. However, I would like to attract your attention to the point that there are nerves which go from the hypothalamus to the locus ceruleus, stimulating the secretion of catecholamines, and on the other hand, nerves which go from the sympathetic system at the locus ceruleus to the level of the hypothalamus. So when we have stimulation of the hypothalamic pituitary adrenal axis, which we call HPA, then this is followed by secretion of catecholamines and vice versa. And this would be really damageful, because you can imagine how our heart would beat if there were not peripheral negative effects reacting as inhibitors in a feedback system. Let's see some paradigms in which the stress response, particularly the chronic stress response, can be damageful and can be translated into metabolic syndrome, either phenotypically and functionally, or even epigenetically. So here is a very nice example of studies which have been done by the team of Sapolsky, including anthropologists and endocrinologists back in the 80s, where they studied groups of this very interesting small animal, the ape of the New World. And the characteristic of this animal is that the females of this animal, they consist groups which have a clear status, social status hierarchy, with a dominant female and a subordinate female. So among other things, they studied their reaction and their behavior regarding their different hierarchical status. And what they found in subordinate female primates, they found that they are stressed, and they present characteristics of receiving more aggression, being more vigilant. They groom themselves less, they spend more time alone, they hypersecrete cortisol, and they have increased heart rate as a response to stress, which results into poor ovarian function, but this is subject of another talk having to do with the eventual involvement in polycystic ovarian syndrome. But definitely these subordinate females, they present visceral obesity and more coronary heart disease. And indeed, the coronary artery atherosclerosis in male and females shows that the dominant female animals, they have the less of arterial atherosclerosis, whereas the subordinate, the males and the ovarectomized, they present important coronary artery atherosclerosis together with increased visceral fat. So here we have some of the phenotypic characteristics of what we call metabolic syndrome, and indeed we all know that these are notions very well established regarding the results of visceral obesity, and I'm not going to go through all these notions that you know better than I. However, I would like to attract your attention to this kind of human being, which could be our patient, which we often see in the streets around us. And actually these are women which present increased visceral fat. They present a less muscular quantity in their extremities, and they even present a small buffalo neck. And actually, although they do not have a Cushing syndrome, they represent a permanent relative hypercortisolism, which can be associated to chronic social stress. And please, let's keep in mind that visceral obesity is characterized by something very important, the presence of the 11-beta hydroxy steroid dehydrogenase enzyme, the one which transforms the inactive form of cortisone to the active form of cortisol. There are two forms of this gene, but the one which increases the amount of cortisol at the level of visceral adipose tissue results to increase cortisol amounts. There are many situations where hypercortisolemia is involved with a resulting metabolic syndrome, but one of them is, as I have already told you, depression, which can be divided and classified in two major forms: the classical melancholic depression and the atypical or the seasonal depression, which have distinct characteristics. Actually, the classical melancholic depression is characterized by people who lose weight. They have increased cortisol. They have to be distinguished in differential diagnosis for their hypercortisolemia in case of clinical approach. They have increased level of catecholamines, and because of increased cortisol, they have increased visceral fat. The result of this increased visceral fat, as you all know, is the development of metabolic syndrome. Whereas atypical depression is characterized by low levels of cortisol. This is why they represent more eagerly autoimmune diseases. But however, they are characterized by hyperphagia. Because of hyperphagia, they have increased insulin levels. Again, they develop visceral fat, and again, both these situations develop metabolic syndrome. So we see here again one example of hypercortisolemia, functional hypercortisolemia, which eventually can be treated and counter-regulated to result to visceral fat and to development of metabolic syndrome. I would like also to add to the stream of this talk some links which have to do with the HPA axis and leptin. As we all know, leptin is a clear indicator of the amount of the white adipose tissue, which has direct actions upon the hypothalamus and hypothalamic nuclei, is involved with puberty, is involved with sexual function, but it is also involved with HPA axis. So leptin is a 16 kilodalton protein, product of the OB gene on chromosome 7 in humans, discovered in 1994, already 30 years back. Secreted mainly from the white adipose tissue in a pulsatile circadian fashion, peaking in late evening and in conditions of food excess. There is a constant interplay between the HPA axis and the adipose tissue, which has not been as yet clearly established physiopathologically, although back there are many publications, both at the level of basic science and at the level of clinical science and the level of animal science, which has given us the opportunity to review them with my colleagues a couple of years ago. And what we found is the following, is that there is a constant interplay between HPA axis, both in acute stress and in chronic stress. So I would like to show you that there are data enough supporting that cortisol secreted by the cortex of adrenals stimulates leptin secretion via increased secretion of cortisol. And the interesting thing is that we clearly know that the leptin which circulates in the body attenuates HPA axis response to stress via direct inhibitory action on adrenal production of glucocorticoids. This is the action of the inhibition, and upregulation of the glucocorticoid response at the level of paraventricular nucleus and the hippocampus, because there is upregulation of the glucocorticoid receptors. What does it really mean, this clinically? We all know that there are people, when we are stressed, some of us, we have a tendency to eat. Does this mean something? Yes, it does. Because when we eat, the leptin levels automatically are increased in our body, and this leptin acutely inhibits, downregulates our HPA action and inhibits the anxiety related to the HPA action reaction and the increase of cortisol. The result is that when we are stressed acutely and we want to attenuate our stress reaction, we eat and we become fatter. So this is a functional involvement for the development of metabolic syndrome. The interesting thing is that when this happens more and more often in a chronic situation, then intolerance is induced to chronic cortisol secretion, non-stimulation of leptin secretion. This leptin secretion is decreased, and also there is non-inhibition of the HPA axis activity at the level of the hypothalamus because the receptors of leptin are downregulated. What I have told you are the results of clear data which are out there in the literature, and we tried to put them together. Is this a possibility that the stress reaction which can be expressed by a mother, by a pregnant mother, could result in utero to development of metabolic clues for the adult offspring when the offspring is going to be born? It seems that yes. So I'll try to show you that maternal insulin resistance can be the result of maternal stress. It is well known that it is also the result of maternal adipose tissue, because we have already heard a lot and very interesting things regarding the development of gestational diabetes mellitus. It is well established that this tripartite unit, including the fetus, the mother, and the placenta, they collaborate for the better outcome of the pregnancy. The genome of the fetus and the genome of the mother is very important for the development of this collaboration, but I would like just to ask you to keep in mind the importance of the placental blood flow, something which for OBGYNs is very important, since OBGYNs, they measure uterine artery resistance in order to understand better the development of, for the good or the bad of pregnancy. So during pregnancy, the metabolic response depends on lifestyle factors and maternal factors, and the combination of these factors can lead to increase or lowering of the glucose levels in the mother, which has its response in the baby. And as you can see, both in the mother and in her lifestyle, obesity and psychosocial stress can be of importance because it can lead to each other. We'll see how. Please keep in mind that during pregnancy, we have three actors having to do with the secretion of cortisol: the cortisol of the mother, the cortisol of the baby, as well as the secretion of CRH from the placenta. CRH of the placenta is secreted in a pulsatile fashion and in great amounts, which results to the silencing of the CRH of the mother. And as we have shown in the past, this CRH is present in the body of the mother, resulting to secretion of ACTH and cortisol. So the result is that pregnancy is a relative hypercortisolemic state. And as you can see in humans during gestation, we'll see the increase of ACTH as well as of the cortisol in pregnant women. And if we notice clinically pregnant women, they present many features, among others striae, among others the increase of facial adipose tissue as hypercortisolemic patients. So what happens if these women, they become obese or if they are stressed? In this very nice cartoon published in this review, you can see how these situations, obesity and stress response, can be the results of environmental factors, genetic factors, epigenetic changes, and they can result to increase of insulin resistance. We'll see how this can happen. But if the result to insulin resistance, this can create epigenetic changes to the offspring, which, as Pat Catalano has already told us 20 years ago, can get this offspring into a vicious circle. So if this offspring is a girl, it's going to become an obese girl, and she's going to develop gestational diabetes mellitus in her turn when she's going to become mother. And this is a very important situation that we clinicians have to break. How the stress response develops into insulin resistance, we have checked it in studies that we have started almost 10 years ago, and they are ongoing, when we have studied pregnant women, normal weight pregnant women, during the first, second, and third trimester of their pregnancy, and we measured hormones of their HPA axis performing as well OGTTs in all of these 3 trimesters. At the same time, we have given them 2 questionnaires, standardized questionnaires, which evaluate their anxiety levels, which we have assimilated to their stress level. And what we have seen is that going from the second trimester to the third trimester and going from the lower score of this scoring of their anxiety to the higher score of their anxiety, we see there is a clear increase of their CRH produced by the placenta. How this happens is because as these women are anxious, they secrete more catecholamines. Their catecholamines result to a reduction of uterine blood flow. This has been clearly shown by OBGYN's colleagues 20 years ago, where they found that there is a clear association between maternal anxiety in pregnancy and increased uterine artery resistance index. So when there is uterine resistance, the blood flow to the uterus goes down. When it goes down, placenta feels an anoxia, and the anoxia results to increased CRH secretion. When we have increased CRH secretion, there is a lot of cortisol in the blood of the mother, and if this cortisol is in increased amounts, can get into the baby, and we all know how deleterious this can be. Actually, when maternal cortisol goes up, there is intense fetal motor activity, as this has been shown in the past. And not only that, this is followed by decrease of insulin sensitivity index. So when the mother is stressed, catecholamines go up, uterine blood flow goes down, CRH of the placenta goes up, cortisol of the mother goes up, and the cortisol of the mother results into decrease of insulin sensitivity, increase of insulin secretion. This mother is getting into a physiopathology of developing gestational diabetes mellitus. So stress can result functionally to gestational diabetes mellitus physiopathology, and not only that, this stress can result to epigenetic changes which can influence all hormonal axes, and among the important one for our talk is the axis having to do with metabolism. And how this can be deleterious when the baby feels increased amounts of cortisol in his or her blood, the nerves of the hippocampus are destroyed. This has been shown also in older human beings. And when we have destruction of the hippocampus, then the hippocampal inhibition of the HPA axis is alleviated, is less potent. The result is that these babies are going to born with a tendency to secrete more cortisol. So when we have a stressed mother in a hypercortisolemic situation, could give birth to offspring which has a tendency to secrete more cortisol and develop more eagerly metabolic situation. Just in 2 minutes, I would like to finish with IUGR paradigm, which is a very important paradigm. Let me remind you the Barker's hypothesis, the fetal origins of adult diseases, Barker studied with his colleagues coronary artery disease death rates among 100,000 men and women in Hampshire, United Kingdom. Between these men and women were born between 19, 11, and 30. Their birth weight was inversely correlated with increased early death secondary to coronary heart disease, and they developed the theory of the thrifty phenotype, where they suggested that fetuses learn to adapt to the environment. Because this was developed in the 80s, we had no idea of the epigenetics. Now we know that the word learn means epigenetical change and epigenetic adaptation. They adapt to the environment, and they expect to enter into to enter into this environment once outside the womb. Several studies indicate that birth weight is not determined by genetic variation, but by prenatal environment. That's what they said at that time. And indeed, you see men who had increased death rate from heart disease before 60 years, they were born with lower levels of birth weight. So these babies who develop intrauterine growth restriction, they are defined as those who their weight or length are less than the 33rd percentile in utero. And this offspring, either in animals or in humans, they are born with increased cortisol secretion, with intensified HPA axis, their HPA axis. And these are now well known to be attributed to epigenetic mechanisms, which are the result either of hyperinsulinemia, hyperleptinemia, and hypercortisolemia. And it is interesting just to tell you that these boys and girls, they develop increased cortisol secretion where they are born, they develop insulin resistance and endothelial dysfunction. And about 15 years ago, one of my students in her thesis has published this very interesting paper showing that these IUGR babies who are born with small weight, they present increased levels of leptin relative to their adipose tissue. So they present hyperinsulinemia, hypercortisolemia, and hyperleptinemia achieved during their IUGR situation in the womb. The result of IUGR is that these boys and girls, they're prone to develop hypercortisolemia, premature adrenarche, PCOS, adult obesity, diabetes type 2, and hypertension, all features of the metabolic syndrome. I'm not going to talk to you about hypothalamic inflammation because this is going to, I'm going to develop it in Goerge for those who are going to follow us there. This is another interesting paradigm associating the stress with the development of metabolic syndrome. But I would like just to conclude as a take-home message that it appears that neuroendocrine stress-related causes of obesity can neuroendocrine stress situation can cause obesity and metabolic abnormalities as a result of environmental and social stressors, including maternal stress during pregnancy, and all of these situations are functional, resulting more or less from epigenetic alterations. Thank you for your attention.
Thank you very much, Professor Goerge, for this very illustrative and interesting talk, and how much you stressed upon the stress and epigenetics, which we are all exposed to the stresses, and we are all afraid of what just you mentioned in your lecture. Thank you very much. And now we are off time, so we are going to close the lecture. And thank you for the audience.